Okay. ¿Los que están online consiguen ver la diapo?
Sí, sí.
Ok, gracias. Sí, podemos dar inicio entonces, ¿ya? Voy a hacer la presentación. Voy a cerrar la puerta. Okay. Muy buenas tardes a todos los presentes, los que están online. En nombre de la Facultad de las Ciencias de la Salud de la Universidad Católica del Maule, les agradecemos su presencia en este evento. ¿Ya? Agradecemos la presencia de la vicerrectora de Investigación y Posgrado, doctora María Teresa Muñoz, nuestra decana, doctora Paula Ceballos, que no pudo estar presente. Saludamos y agradecemos la presencia de nuestro profesor invitado, el doctor Raffaello Furlan, quien dará la charla Orthostatic Syndromes, Diagnosis, Treatment, Insight into the Autonomic Nervous System. El profesor Furlan es profesor titular de Medicina de la Humanitas University, director de Medicina Interna y Unidad Syncope de la Humanitas Research Hospital. Fue investigador principal de estudios clínicos destinado a evaluar el control neurovegetativo del sistema cardiovascular en condiciones fisiológicas y fisiopatológicas y, más recientemente, ha trabajado con el uso de inteligencia artificial en la identificación y estratificación de riesgo de síncope. Es autor de más de 150 artículos científicos publicados en revistas internacionales y varios capítulos de libro. Así que damos la bienvenida al profesor Raffaello Furlan. Professor, thank you very much for being here. It is our pleasure. I'd like to thank you also, Anid and Fondecyt, that make this possible. Okay. So, Professor Furlan, it's our pleasure to have you here. Please feel free to start your talk. Okay. So I will start from here, and okay. Do I have the chance? Can you see my pointer? No. No, you don't see my pointer. Anyway, and here you just see here the pointer. Okay. So let me first of all thank Professor Roberto Antonio Zamunér for this great and kind invitation. It's I'm mostly honored to be here in such a great university with such friendly people. So really thank you again, because this meeting gives me the possibility to share with us a part of the work I've done in research during the last 20 years. And as a matter of fact, part of this research was done with the help of Professor Zamunér, whom I know for many years and who I respect as a great researcher. So today I'm going to share with you the concept of orthostatic intolerance, and we will see the orthostatic intolerance in two ways. The first one is we will address the problem of the orthostatic hypotension and how we can make a diagnosis, what orthostatic hypotension entails, and what is the what are the therapeutic options. The second part of my Okay, there must be somebody possibly from the web. Those of you who have got the microphone switched on, please switch it off. Okay, so now there is no more noise in the background. So I was saying that the second part of my talk will deal with a quite unique population that is not well known nor recognized, that is called POTS, and we will address the aspects of orthostatic intolerance in such a disorder. So what is orthostatic hypotension? Let's see, first of all, the potential definition and diagnosis. We define orthostatic hypotension a decrease in systolic arterial pressure greater than 20 millimeters of mercury compared to the supine position after 3 minutes of the upright position. There are two variants of orthostatic hypotension. One is called delayed orthostatic hypotension, which occurs mostly 3 minutes after the onset of the standing up position, and it is quite often present in aged individuals and may be a sort of dysautonomia. But there is also this initial or transient orthostatic hypotension, this one I was mentioning, that to some extent may express a mismatch between the cardiac output and peripheral vascular resistance, and it occurs early, 17 seconds after the onset of the upright position. Every kind of orthostatic hypotension may be diagnosed with different devices. So the most common one, the one I first mentioned, can be diagnosed by a simple brachial sphygmomanometer, whereas delayed orthostatic hypotension requires different devices because you need a bit-by-bit blood pressure assessment in order to follow blood pressure over time. Let's go on. And let's say a couple of things about epidemiology. Orthostatic hypotension may be present in up 6% of the population. However, its prevalence is increasing with age. And this slide shows you the increase in the rate of orthostatic hypotension according to the different, here on the left part of the slide, of the different ages. If you look at the syncope as a side effects of orthostatic hypotension. In this sense, in people older less than 40 years, orthostatic hypotension is present in about 2.5%, whereas it goes up to 30% of the population aged 75 years or more. So there are few key points I would like to address briefly today. The first one is, the first key point allowed me to highlight the concept that orthostatic hypotension is an independent risk factor for mortality, acute coronary events, and stroke. And this is quite important because, as you may be aware, the large majority of the physician or researcher dealing with hypertension, that they claim, and even guideline on hypertension, they claim that having a low blood pressure is good. This is not always good, as a matter of fact, okay? And this indeed is the case of these Kaplan-Meier survival curves that were done by Rose and collaborator and published in 2005 in Circulation, showing how those people who were suffering from orthostatic hypotension had a worse survival up to almost 1 year and a half as compared to those people who did not suffer from orthostatic hypotension. And those other curves are in keeping with the same concept. So cumulative rate, cumulative death rate, stroke rate, coronary events, and here we have the composite endpoints which put everything together. Okay, in all those examples, those people who were suffering from orthostatic hypotension had a better outcome, had a worst outcome as compared to the normal population. So, symptoms. From the web, if you do have some question, try to switch on your audio and interrupt me, which is the same for you guys. If you need a question, just raise the hand, interrupt me. We can have an interactive. So symptoms. What symptoms would you guess a patient with orthostatic hypotension may suffer from? Is anybody who wants to tell me something? I'm going to repeat in a loud voice just to make the story a little bit more interactive. If blood pressure is low and I'm standing up, what happened to me? Dizziness. But let's see more. And this is correct. But there is a but. Okay. So sometimes you may have no symptoms, although you are suffering from orthostatic hypotension. Let's make an example. If my blood pressure is 140 when I'm lying down, and it comes up to 110 during the upright position, systolic blood pressure meaning, well, there are criteria to define my hemodynamics orthostatic hypotension, but nonetheless, with 110 millimeters of mercury, I can easily stand up and even talk to you like, well, possibly I don't have a greater blood pressure presently. Okay, so you may have no symptoms, so no orthostatic intolerance, but orthostatic hypotension. Alternatively, we may suffer from symptomatic orthostatic hypotension. And dizziness, as you somebody there correctly said, is one of the symptoms together with a blurred vision. Weakness, the patient is feeling tired. Okay. Lightheadedness, I like very much this English word. Lightheadedness meaning that lightheadedness meaning that your head is light. Okay, is something dealing with a cloud. Okay, in the sky. Vertigo, and we call basically all those symptoms pre-syncope symptoms. Okay, apologize. The last word would be pre-syncope symptoms, not pre-syncope syncope. Okay, but syncope may be the last and ending point of this condition. So there is a 5-item questionnaire which was developed by the Mayo Group, led by Philo, which is able to quantify the intensity of the symptoms of orthostatic hypotension. Possibly I'm touching the cord, so I'm interfering with the quality of the slide. I apologize. And so you may have 3 levels of intensity: 0, 6, 7, 13, which is moderate, and 14, 20, which is severe. So we can quantify the intensity of the symptom. Is that important? Yes, it is. Even for you here, because it may allow you to follow over time the time course of the disease of your patient. I know few of you up here are interested, for instance, in Parkinson's disease, and this might be very important for Parkinson's disease, for example, okay? And I'm going quickly to show you how the questionnaire do assess the intensity of symptoms. First of all, the questionnaire there are a number of questions addressing the frequency of orthostatic symptoms. From 0, I never or rarely experience, up to 4, I always experience orthostatic symptoms. So it's a score. So every answer counts for the value. And by the end, you make the sum, you add all together, okay? So frequency, severity of orthostatic symptom, I do not experience, up to I experience severe orthostatic symptoms when I stand up. Conditions which so rarely experience orthostatic symptoms, up to I always experience orthostatic symptoms when I stand up, conditions. Okay, activities associated with the onset of orthostatic symptoms. Okay, so from 0 to 4, my orthostatic symptoms severely interfere with my activity of daily living, and the standing time in minutes. So this is an objective way to assess the intensity of the orthostatic hypotension. So how about the causes leading to orthostatic hypotension? We have got basically 2 mechanisms leading to orthostatic hypotension. One is hypovolemia. The second one is represented by abnormalities in the cardiovascular neural autonomic control. Okay, so our autonomic nervous system is not able to properly control blood pressure when I'm standing up. And let's go to see this slide, which shows you what is gonna happen when we stand up. When we stand up, there is a venous pooling with a decrease in the central venous pressure, in turns leading to a reduced ventricular filling, right and left ventricle filling. This tends to reduce the stroke volume and blood pressure, but this phenomenon is sensed by baroreceptor mechanisms that are placed here in the aortic arch and at the bifurcation of the 2 carotidous vessels, okay, and through the 10th vagal nerve afferents and 9th nerve, which is the glossopharyngeal afferents, they project information to the brainstem, and those information, they go to the nucleus tractus solitarius. They are modulated by hypothalamic and cortex influences, resulting in an increase in the sympathetic activity to the heart and to the vessels, leading to an increase in heart rate and stroke volume, an increase in norepinephrine release, which has a powerful vasoconstrictor effect. So it induces arterial and venous vasoconstriction. There is an increase of the sympathetic activity to the kidney, and we can assess the sympathetic activity to the vessels by recording what is called a muscle sympathetic nerve activity. Okay, and we will talk about the muscle sympathetic nerve activity later on. I'll show you what really this is. Okay, and this is an example of a normal behavior during, this is an healthy subject while recumbent, which means in the supine position, during a 75 head-up tilt test maneuver. So there is an increase in the heart rate. Blood pressure doesn't change that much. There is a small decrease in the differential blood pressure. Respiration doesn't change. There is obviously a drop in central venous pressure and a huge increase in the discharge activity of the sympathetic postganglionic fibers towards the vessels. So if we compare the number of bursts here during tilt with the baseline values, you see that the upright position is associated with a huge increase of the sympathetic activity to the vessels. So this is a normal behavior. However, there are causes, there are conditions which may impair such a normal behavior, and I here summarized. They are aging, which we already dealt about, long-term bed rest, which is a condition that you, as a kinesiologist, will be very interested in. You have to rehabilitate a long-lasting bed-confined patient, okay? And so you have to take into account this variable as potentially and as not only a potential variable, but this variable is also very powerful in inducing orthostatic hypotension. Drugs are very important, and of course, disorders, diseases affecting the autonomic nervous system, either central, like Parkinson's disease, or peripheral, like for instance, neuropathies associated with diabetes mellitus, with alcoholism, and so on, okay? As I said, we have already talked about aging, but just consider that in 7% of normotensive age individuals, you may have orthostatic hypotension, and this rate increases up to 30% if patients are suffering from other diseases, okay? Those are the pathophysiological mechanisms leading to orthostatic hypotension in aged individuals. Today, I'm not going in detail to address these issues, but you may find them out and work on those. I guess I will leave Professor Zamunér this presentation. If you are interested, you will read it and discuss among you all the concept. Okay, long-term bed rest. And here are three conditions accounting for the orthostatic hypotension associated with long-term bed rest. Long-term, I mean 2 weeks or more. Okay, so there is a relative reduction of circulating plasma volume due to a cardiopulmonary redistribution. Okay, this is something that happens also in the weightlessness in astronaut. If you pay attention to the face of astronaut, okay, they will be puffy, so with edema, and this is because the absence of the gravity force pushed the blood into the thorax, so the venous returns from the head is difficult, resulting in cerebral edema and in a puffy face. Cerebral edema incidentally accounts for a very annoying headache that astronauts are suffering from when they are in the absence of gravity force. Okay, we have a bad experience about that. We have pictures showing astronauts always smiling. they do not smile. They don't feel okay when they are up in the international station without gravity force. They feel nauseated all the day around. They feel headache because of those kind of. So don't forget that long-term bed rest is a maneuver which mimics the weightlessness condition, the absence of gravity force. What is happening in the international station rotating over the heart, the earth, okay? Second mechanism, left ventricular remodeling with a reduction of left ventricular dimension and cardiac output. Third mechanism, the reduction of leg muscle tissue, particularly in the elderly. And this is an issue where you guys have good chance to work on. This is up to you, to your capability to convince the patient long-term bed confined to do physical exercise, appropriate physical exercise. Drugs, even if you are not medical doctors, please ask always your patients suffering from orthostatic hypotension what drugs they are getting. Okay, all drugs inducing hypovolemia or affecting the sympathetic nervous system response or creating directly vasodilation, all those drugs may induce orthostatic hypotension. Okay, can I ask you guys an example of a drug inducing hypovolemia? The one you give patient with heart failure? Diuretic. Okay, they are at high risk of creating orthostatic hypotension. Vasodilator. Men are used over 60 to suffer from prostatic hypertrophy. And the most effective drug, talmuzolin, was developed as an alpha-lytic compound. And in doing that, you have associated vasodilation, which may result in a huge orthostatic hypotension. Okay, so for example, Parkinson's disease, guys, double check if they are getting any drug for prostatic hypertrophy. And please, if possible, take it away. You will improve the orthostatic hypotension, okay? Disorder affecting the autonomic nervous system. Today I'm gonna focus on the Parkinson's disease, given that in this university, and in particular in the laboratory led by Professor Zamunér, a very important protocol on Parkinson's disease patient is ongoing. And so I think we have to spend a few minutes about that, okay? Orthostatic hypotension affects more than 50% of patients suffering from Parkinson's disease. And among them, more than 60% are suffering from symptoms and signs of orthostatic intolerance. So in the past, it has been shown that these patients, they may have a dysautonomia affecting the neural control of the heart. But nobody was done about the dysautonomia affecting the vascular blood pressure control. And so we did a study on trying to address this problem, comparing a group of control subjects with two groups of Parkinson's disease, a group suffering from orthostatic hypotension, and one group without any orthostatic hypotension. So it turned out that those with orthostatic hypotension couldn't increase the RR interval, which means couldn't increase the heart rate properly as compared to healthy control and the other group of patients, as well as this index, LF-HF ratio, obtained from heart rate variability. And this other index, the low frequency component of systolic arterial pressure variability, those two indexes also were impaired. So this tells us that the sympathetic control of the heart is impaired. This delta LF sub tell us that the vascular sympathetic control is impaired. But what is very interesting is that even in those Parkinson's disease patients, see the blue circles, okay, even in those patients who were not suffering from orthostatic hypotension, even in them, the capability to increase heart rate and the sympathetic activity to the heart and to the vessel was impaired as compared to healthy control, represented by the green circle. So that means that there is an early alteration in the autonomic neural control in Parkinson's disease preceding the onset of orthostatic hypotension. Let's see some specifically related issue. What do I mean with that? Some tips. I would like to give you some tips, something you won't find out on textbooks, okay? First of all, in more than 50% of patients with dysautonomia, including Parkinson's disease patients, orthostatic hypotension is associated with clinostatic hypertension. So there is a profound mismatch. And the mechanisms for this behavior are quite complex, still not completely understood. I won't go in details into the mechanism, but what is very important for you guys, as well for us as medical doctors, as physicians, is that there are clinical criticity problems, okay? Mostly the fact that clinostatic hypertension may produce organ damage and needs to be treated. There is incidentally a high rate of night mortality in these patients, and this is probably because of the excessive increase in blood pressure during the night. Okay, and second point, most of the time, if we have to give a patient a drug because of hypertension, we used to give the drug early in the morning. This is not the case in these patients. You have to shift the anti-hypertensive treatment to the night hours in order to control the night hypertension. Okay. Otherwise, during the day, you will make a mess, a disaster, because you will increase the you will make the orthostatic hypotension even worse, giving in the morning such a treatment. And this is an example of what I'm saying. So it results in an inversion of the day-night circadian rhythm of blood pressure. I'm very linked, emotionally linked with this graph, with this cartoon, because this was a dysautonomia patient, the first dysautonomia patient I studied, and this is an invasive recording of blood pressure. That means that at those times, we had a special system which we developed, having a catheter going into the artery of the patients up to the level of the heart, in the brachial artery, recording blood pressure on a beat-by-beat basis and recording the signal on a tape recorder. Was an Holter recorder modified, which we modified, okay? And the patient was able to move freely into the hospital. So he was able to do physical activity, to take a nap, lying awake, sleep during the night. So please notice that during the night, the mean pressure is greater than during the day, especially when the patient was doing physical activity. Now I'm asking you guys, based on this kind of hemodynamic behavior, how would you think this poor patient is feeling when he has to deal with physical activity with, 60 millimeter of mercury or maximum blood pressure, when he had to walk up stairs, for instance, or just walking? He will feel tired, exhausted, he will feel miserable. And that's the quality of life of these patients. Test. What test would you do? So we said that we can do the diagnosis just asking the patient to stand up. Okay, and we compare the drop in blood pressure as the value of blood pressure, in the upright position with the lying down position. Okay, so is there any test you may think could be crucial, mandatory? That's correct. That's correct. An active standing test is just enough what you have to do. But nonetheless, I would like to show you what we can do in our laboratory. Okay. And I would like to focus on the Valsalva maneuver and on the controlled breathing, on the tilt table test, and saying a few words more on the ambulatory blood pressure monitoring that you have already seen just now. Okay, this is a normal behavior in a normal subject when I'm asking the subject to breathe following a metronome or following the rhythm I'm giving him. Okay, this is the sinus arrhythmia test. So we are asking the patient to breathe in, out, out, in, exhale, exhale, inhale. So we follow this 10-second periodicity, and in doing that, we induce a powerful stimulation to the center controlling heart rate. So you may see the spontaneous fluctuations in RR interval, which means heart rate, basically, which are enhanced during this kind of maneuver, and we can make the ratio between the maximum and the minimum level, obtaining a value, and this is the normal value in our lab. So please look at what is going to happen in a Parkinson's disease patient suffering from dysautonomia. So can you make a comment for me about the RR interval, the spontaneous variability of heart rate? So that is the normal behavior. This is the patient's behavior. What would you see? How would you comment? So there is no variability. Okay, and this absence of spontaneous variability cannot be elicited during my test. You see, so the patient definitely change the respiration pattern. Okay, he is going to breathe more deeply according to the rhythmicity, but we could not elicit any variability in blood pressure, in heart rate. And indeed, in this case, the ratio was clearly abnormal. Okay, so in this way, we can follow the transient from a normal up to an abnormal pattern. Let me show you the Valsalva maneuver as it is seen in an healthy individual when we are recording the ECG, the heart rate, the blood pressure, the cardiac output, the total peripheral resistance, the respiratory activity, and the muscle sympathetic nerve activity, which that I'm remembering to you, I'm recalling to you, is the recording of the postganglionic sympathetic activity going to the vessels. So every single burst represents, so this and this and this and this and those are a number of single sympathetic fibers discharging together, firing together, okay? So please notice that when, so do you know what is a Valsalva maneuver? Let me remind you the concept. So you give a patient a syringe, which is to keep into the mouth, and this syringe is connected to a sphygmomanometer. And you ask the patient to take a deep breath, inhale, and to blow into the syringe in order to create a pressure of about 40 millimeters of mercury for 15 seconds. In doing that, you impair the blood return to the heart because there is an increase in the intrathoracic pressure. So there is less blood which arrives to the heart, and thus blood pressure is going down. Okay, so look at the blood pressure. This is a beat by beat recording of blood pressure. Is going down, okay? And this elicits a reflex increase in heart rate and of the muscle sympathetic nerve activity, which is mediated by arterial baroreceptor. So in this way, you can assess the arterial baroreceptor function modulating either the heart and the vessels, okay? Please notice that when the patient is asked to release the strength, when he started to breathe again normally, there is a blood pressure overshoot. So in a few beats, blood pressure goes up over the baseline values, and reflexively heart rate goes down, and there is no more sympathetic activity. There is a neural silence. Okay, so again, this is a normal behavior. Look at what is going to happen in an individual with dysautonomia. So you have the increase in blood pressure, phase 1, decrease in blood pressure, but there is no reflex change in heart rate. Okay, in spite, okay. And there is, in addition, no overshoot in blood pressure during phase 4. And in this case, the Valsalva maneuver is absolutely abnormal. Okay, because for the Valsalva maneuver, again, you can, sorry, I didn't say to you, but you can assess the maximum, you make the ratio between the maximum and the minimum level you reach, and you can easily have an index of the arterial baroreceptor function. Pure autonomic failure. Okay. Pure autonomic failure. This is another type of dysautonomia. And please notice that when I'm tilting up at 45 degrees head up the patient, apologize, there are no changes in heart rate, no reflex changes in heart rate, and there is a dramatic drop of blood pressure. Okay, you see the mean blood pressure. So the patient may pass out, may suffer from syncope. Okay. And this is ambulatory blood pressure monitoring. This is a normal dipping pattern. So during the night, blood pressure tends to go down. In dysautonomia patients, we may have a non-dipping pattern or a reverse dipping pattern as the one we have seen. So blood pressure is characterized by greater values during the night as compared to lower values during the day. Therapy. This is a cartoon summarizing what the European Society of Cardiology, based on our suggestion, thinks that has to be done in orthostatic hypotension, in symptomatic orthostatic hypotension. First of all, education, lifestyle measures. We will see what this means. This is a crucial point for you guys. Education is a cornerstone for your activity. Okay. And as well as the capability to suggest proper lifestyle measures. Please double check the hydration of your patient and if possible, convince him or her to increase salt intake. Of course, stop or reduce potential vasoactive drugs if present. If symptoms they persist, we may rely on counter pressure maneuver, compression garments, head-up tilt sleeping, midodrine, fludrocortisone, and other. Please, I will go a little bit slower in this slide. So we have to eliminate all the causes of hypovolemia and try to increase the intravascular volume by giving per os water and sodium. I'm suggesting my patients to get salt, cristal, how do you say in Spanish? Cristal. Cristal, okay, in order, the one we use to cook pasta. Okay, so we call rough salt as compared to the teeny salt, okay, which is used for salad. But for the water of the pasta, we use that kind of salt. Give them some of those. They can put into the mouth, melt it, and drink water. Crucial, second point. This is crucial, guys. This is crucial, and it is absolutely up to you. Early mobilization of the patient and kinesiotherapy. The aim is reduce as maximum as possible the time of bed rest for those patients, especially for those patients who are hospitalized. So what's going to happen here? I'm afraid there is a connection problem. Okay. What do you think? See. Okay. Okay, so this is something we are always claiming with our nurses and with our kinesiologists or physiotherapists. It doesn't matter. I mean, that are in charge of the patient. We need to take the patient off from the bed soon, very soon. Okay. Physical counter maneuvers, leg crossing to raising, tight contraction. I'll show you a slide, but you may say Professor Zamunér, who is not suffering from orthostatic hypotension, nonetheless, as well as Fernanda, they are keeping their leg crossing because in this way, they keep attention on my talk. We are not going to fall asleep because I'm boring you guys. Okay, so there is this risk, but keeping your leg crossing, blood pressure is high, you can be awake. Okay. We may use waist high compressor stockings or abdominal binders, which are not very diffuse and popular in Italy. I personally, I'm suggesting, based on the personal suggestion of my American chief and boss, David Robertson, I personally suggesting caffeine before eating, and possibly a light reduction of carbohydrate intake at lunch, but caffeine before eating, which is strange, right? So they have to take coffee. I say, well, you are a lucky man. I say that you are a lucky man because now your wife is gonna take in the morning the coffee to you while you are lying in the bed. You get the coffee. This is not a breakfast. This is a medicine, a drug. You take the coffee, you stay lying down for 5 minutes, and then start the day. And then start the breakfast, possibly having additional coffee, okay? Or coffee before lunch. Have you heard about meal hypotension? Those patients are suffering from terrible bout of blood pressure decrease while they are eating. They feel drowsy, they feel sleepy, their speech slow down, they could keep concentration. So ask the witness and the relatives, how is doing your pa, your mom, your cousin? Is he alert? Does he get angry watching television news? Okay, or he is passive, just it seems he is watching television, but you know, in the second case, he's suffering from orthostatic hypotension during meals. Okay, and so a good suggestion is try to keep the patient in order instead of, okay, let me do this example. Okay, this is a sitting position. Okay, ask the patient, you put something under the leg in order that is a sitting position without a gravitational stimulation. This ameliorates the situation. Okay. Water. So how would you consider water? Is water an inert agent? For example, all the clinical trials on blood pressure are using water. Of course, if you have to test a drug, you get a tablets, a pills, you need water to swallow. Well, it turns out that in dysautonomia patient, water is a powerful pressure agent, very powerful, and in aged individuals also. So keep in mind, for your grandpa, your grandma, a glass of water may make the difference. Water peros was found to increase blood pressure more than 20 millimeters of mercury for about 2 hours. This was published in Circulation. This was an observation we did when I had the opportunity to meet with Jens in Nashville, and our group was astonished. And somebody was claiming that it was because of the water of Nashville. So you say somebody put something into the water, but that was not the case. Also in Italy, okay, this is an example of what happened to one of my patients, lying down, gave here time 0, almost half a liter of water, 580 milliliters. You see in a few minutes, there is an increase in systolic blood pressure, which is continuous up to more than 1 hour and a half. Okay, those are micturition times. And those are the physical countermeasures. We just measured crossing leg, going on your toes, squatting. Squatting is crucial, or, you know, here, this is something that my patients tend to do. Okay, so ladies are crossing or are keeping the hands together, whereas men, they usually do this one, and so they and this one, and across their leg, so they can face somebody and keep conversation while standing up without moving. Okay. Pharmacological measures. This may be not crucial for you, but just in order you know what you can do. Midodrine. Okay. Ask me, are you happy about midodrine? No, not that much. It's not working that much. I would like midodrine working much better, being an alpha-1 agonist. Okay. Fludrocortisone. It's a very powerful cortisone with very few and very low anti-inflammatory effects, but huge capability to absorb sodium and water. And so fludrocortisone is given because of that. Pyridostigmine may increase ganglionic transmission. Do you know pyridostigmine is used for myasthenia? Okay, but you know it may work. And droxidopa is the newest drug, has been recently approved by the FDA. There was, you know, the press. There was a huge interest for this drug. This is a pro-drug. So it's breakdown into plasma norepinephrine, and so there were high interest for this drug. But unfortunately, this is my experience. We have been using it not since few months. Okay, it's quite costly, and we in Italy we need special permission to import from Japan. Well, I'm not very happy about the droxidopa also, okay. Other drugs are paroxetine or reboxetine. Those are inhibitor of serotonin reuptake, paroxetine, as you may remember, okay. And reboxetine theoretically is the best drug because it's a pure inhibitor of norepinephrine reuptake. But again, those are antidepressant drugs. You may use them because these patients may be depressed as a consequence of their orthostatic hypotension. So they may help. In other words, we do not have a single drug or a single counter maneuver, but if we give all together, reasonably, of course, we may help the patient to improve his life. Now, let me finish this first part. Hopefully it was not too boring, mentioning this possibility of autoimmune autonomic ganglionopathy. So in about 50% of patients suffering from orthostatic hypotension because of a dysautonomia, it is possible there is the presence of autoantibodies that go and link to the cholinergic receptors. So it's they basically tends to link to the nicotinic ganglionic cholinergic receptors. We are talking about the ganglia, okay? So sympathetic efferent activity, and those, it is thought that those autoantibodies may interfere with the neurotransmission. So the rationale is, can I take off, can I clear the blood from those autoantibodies? If I were able to take them away, possibly the patient is doing better. And it turns out in our experience, which we published on Journal of Hypertension in 2017, that was the case. We had this patient who is still living, and I've been following him, I would say, for more than 25 years. And at the very beginning, he is really a unique individual. I mean, he was a worker working on a line in the steel industry. So he had to stand up on the line, and every single piece he had. You have in mind Chaplin movie. Okay, in Italian it's called Tempi Moderni, modern time. He had to keep on going, and he was following when he was, touching. He had to. Okay, but that's another story. Basically, my patient was a person working on them, standing up all the day long. And so by the end, she said, "Well, doctor, what can I do?" So we convinced the boss, letting him sitting down a little bit. Okay. And in that way, he could go on for additional 1 or 2 years because he liked his work. And in addition, he had to work. Okay. And so just close by his retirement, we came, we got in touch with this possibility. And we convinced our good friend, the neurological, immunoneurological board or department of the Ospedale Vesta to set up a special assessment for those autoantibodies. And they could do that. We could identify huge level of autoantibodies. He went this immunoglobulin G protein immunoadsorption. Basically is a dialytic technique. And he did several times this technique together with the cortisone immunosuppressant drug, and he did much better. So he was able to go on a little bit on his work. He could paint his house. Can you imagine painting himself the house? Painting his house. Have you ever painted your room? Oh, by the end of the day, you are exhausted. You can't, okay. And he painted his room. And you want to know the best thing to me? What is the first symptom that these patients are suffering from, especially male? Sexual disorders, impotence. This is the first problem. And most of the time, the urologist is saying, well, it's just a matter of orthostatic hypertrophy. Come, I will resolve every problem. And of course, that was not a problem. So to make a long story short, this guy started again to make love with his wife, which is something I love. I think it was our best achievement. So we gave him the full life again. He was able to paint as well. He was able to go fishing. He was very fond of that, with more interest. And, just he's now 75, something like that. So I wouldn't say that every single night he's having love with his wife, but, reasonably he's still doing love with his wife. So this is something. Okay, if you want, we can make a 3 minutes, 5 minutes stop. I'm available for. Are we late? No, you're fine. I'm available for questions from you guys and from the audience from the web. If somebody would like to know something, guys from the web, have you got any question for me, please? I can't hear. Probably everybody's sleeping. Have you got any question?
Puede ser en español si quieren, yo puedo hacer la traducción.
Yeah.
They're asking when the patients are with vasoactive drugs, what do you think about the kinesiologist's work? Do you recommend they to receive kinesiology treatment or kinesiology exercise should be suspended our own
Okay.
vasoactive drugs?
Hopefully, so the point was, I'm repeating for those who are in the web, otherwise they will understand. So the question from the audience, from one professor, I forgot your name, I apologize, was asking if for those patients in whom orthostatic hypotension was mostly due to drugs, if I were recommending the kinesiologist intervention. Was that the point?
The patients are still on the drugs.
Yeah, and if the patients are still on drugs, I was doing exercise and so on. So my position is, I will go step by step so you may translate, that I'm always recommending physical exercise, which a kinesiologist knows much better than I how to organize. Okay, we discussed with Professor Zamunér the issue. I tended to suggest either isometric exercise, very simple, okay, and aerobic exercise. At the beginning. So basically,
See? See? Are there any environmental risk for orthostatic hypotension?
yes. It seems that if you go in detail, you ask a history, and you need time. To be a good doctor, you need time. So you have to go in detail, and you go in depth, and some of these Parkinson's disease, for instance, patients, they were exposed to hydrocarburic, or I knew a couple of them working at a gas station, providing cars with gasoline. So there are definitely environmental reasons. There are mechanical reasons. Boxing is associated with a higher rate of Parkinson, and there are genetical reasons. Okay, but coming to your point, I'm suggesting isometric exercise, like the one can do. I'm a simple guy. You are the sophisticated kinesiologist, but I'm suggesting my patient to lie, take this position, and count up to 10, 15. Okay, they stand up, they relax yourself, and they do again 4, 5 times. They say every single hour they use the telephone. They organize every 50 minutes. They have to do exercise for 10 minutes. This is roughly speaking what I'm suggesting. And meanwhile, in the afternoon, You may know that in those disorders, there is a circadian rhythm. People feel miserable in the morning. The morning is the worst. They say, well, I'm gonna die. I would like to die. I have no energy. But for some reason, and we do not know the reason, during the afternoon, blood pressure is, or they feel much better. Not always because blood pressure is a little bit higher, but just for some reason we still do not know. And so taking advantage of the afternoon, I'm convincing the family environment to push the patient out of the house. If they have a wheelchair, say, well, go out with the wheelchair. You will not sit down. You will just put the wheelchair, which incidentally opens the questions that those patients, they do not want to go outside the house because they are shy. They
They are ashamed.
They are, yes, because they say, well, I'm so impaired. People is going on what they are going to tell about me. But I say, well, you are pushing somebody else wheelchair, somebody else. But whenever you feel tired, you feel dizzy, you break the wheelchair, you sit down, and things. So that helps you to keep on going.
I have some question from the web.
Yes.
Vanessa is asking, thank you for the excellent class. I'd like to talk if tilt training will be important for this patient.
Training of what?
Tilt training.
Tilt. Oh, yes. Vanessa, thank you for your question. To some extent, there is a sort of training to gravity force, which is very important because these patients with orthostatic hypotension, they feel much better if they sit down or lie down, of course, and they tend to be deconditioned to the gravity force. So if we can force them to stay upright, things are improving. But what do we mean by tilt training? The fact that we suggest the patient to put under his or her bed, I mean, we call them piedini. A bed can stand upon 4 legs, legs of the bed. Let's call legs of the bed, okay. You have to put something under the legs on the side of the head. In order, all the bed is inclinating, having the head, the neck, the trunk higher than the abdomen and the leg. Okay, don't use leg beds. How do you call it? Letti articolati in Spanish, or articulated beds could be, okay. They are not working. You just need to put a brick under the leg on the side in order everything is slightly tilted. And this is a way to improve orthostatic intolerance in the morning.
Have another question from the web, Valeria.
Valeria, thank you.
To study the role of vagal tone, what would be a good drug to stimulate and another to block vagal activity?
Okay, so your hypothesis is that if I'm going to shut down, to switch off the vagal activity, the remaining sympathetic activity will help the patient. But, unfortunately, that is not the case. We have seen orthostatic hypotension is a chronic condition, okay? And the patient at the beginning tend to adapt slowly to this impairment. in the vascular and cardiovascular better neural control. Okay, so even the vagal activity is switched off, because one would expect in the absence of sympathetic activity to see an excessive bradycardia, huge bradycardia, but that is not the case. Okay, there is the intrinsic heartbeat activity, so the beat is always the heart is always beating around 70 beats per minute. So in this case, drugs which may enhance or reduce the vagal activity are not useful at all. We will see, if you will be patient, how we can increase the vagal activity in POTS patients, my next presentation, by using the electrical stimulation of the vagal efferents in the right out air part of the body. So stimulating the airs in the right ears may help to increase the vagal activity. Okay?
Last question from the web.
Okay.
About cardiovascular rehabilitation for these patients. That some patients present, some patients with the cardiovascular rehabilitation present orthostatic hypotension. So Vanessa also asking, do you believe that cough exercise could help this with the treatment?
Yeah. Can you help me to figure out what is
Cough exercise? Yeah.
of the just going on your feet?
Yeah.
Basically, this absolutely, Vanessa. I think it's first of all, it is a countermeasure you can use acutely. Okay, instead of staying immobile, going on the tip of your feet to some extent may help you doing this movement. I don't know if you see me going up and down, but this is a great movement. Okay. I guess the mechanism is that because you are in doing that, you are pumping, you are pushing blood to the heart on one side. On the other, you are activated sympathetic. You are activating muscle receptors, resulting in a reflex increase of the sympathetic activity to the vessels and to the heart. Okay, so there is also an increase in the neural activity. Yeah, please, when we talk about dysautonomia, never forget that dysautonomia is never absolute. Okay, so patients still have a small amount of sympathetic activity they may have. Okay, the point is that it is too low. But why? I guess. Do you want me to go on? We can. Because I'm afraid people from the web, they will leave, they will go to bed definitely. Okay, because I would say that half of them are already sleeping, I guess, and yeah. Or would you like to have a 5 minutes rest? Okay, for those who are interested, this presentation will be available by request to Professor Zamunér, okay? And I'm talking now about POTS. This is quite interesting. If you have still some energy, okay, I know you are busy, don't worry. Thank you for being here. Thank you very much. Okay, thank you. Thank you very much. Okay, what is interesting in this disorder is that Okay, can you tell us, can one in the, please guys in the web, can one of you tell me, opening the audio, if you see my slide? Please, one of you, okay?
Yes, we can.
Okay, thank you very much. Very kind of you. Very kind of you. Okay, what I'm saying is that this disorder is quite interesting nowadays. Guess why? Because to some extent, this resembles, or I would say this overlaps what we call the long COVID. Okay. Quite a large number of people suffering from long COVID and being young, they do have symptoms and a hemodynamic pattern similar to the one of postural orthostatic tachycardia. Okay, so what is this POTS, or postural orthostatic tachycardia syndrome? Basically is a orthostatic intolerance disorders, which means, roughly speaking, which deals with the inability to maintain the upright posture, incapability to stand up. What do you mean? Are you going to fall? No. Simply the patient doesn't feel okay when he, or most of the time she, is in the upright position. And so basically she tends to start a vicious circle. So those ladies are spending more and more time sitting, and they by the end discover that sitting with the leg up is even better. And they by the end discover that lying down, being supine, is the best for them. They feel okay. And this, of course, is a tragedy, because they become highly gravitational force deconditioned. Okay. So far in the first part of my evening talk, we talk about orthostatic hypotension. Now we are talking about postural orthostatic tachycardia syndrome, POTS. What are the differences among the two conditions? Just to make the story quite simple, in orthostatic hypotension, we deal mostly with elderly subjects, so individuals whose age is greater than 45 years, whereas in POTS, we have people whose age ranges spans between 15 and 45 at maximum. There is a clear rate 4:1, which means that POTS is much more frequent in female than in male. The rate of occurrence is about 500,000 per year in US, and the most important hemodynamic difference is that whereas orthostatic hypotension is characterized by a drop in blood pressure with minimal or no changes in heart rate, in POTS, blood pressure is maintained in the upright position, whereas the heart rate undergoes an excessive increase. So there is a huge increase in heart rate without changes in blood pressure. And this is really tricky for you. You said, how can't you stand up with such a good blood pressure? We will see the problem. So most of the time, orthostatic hypotension ends out with syncope, with loss of consciousness, whereas syncope is quite rare as far as my experience is concerned in POTS. Okay, they have huge orthostatic intolerance, but not syncope, not going to syncope. Okay. Finally, whereas orthostatic hypotension is widely studied and well characterized in terms of pathophysiological mechanism, POTS still is poorly characterized in terms of pathophysiology. So we have to understand a number of things dealing with POTS so far. What is POTS? So definition is a clinical syndrome. So it's a number of symptoms with a different pathophysiological explanation, characterized by an increase of heart rate of at least 30 beats per minute or more in within 10 minutes of standing up or head-up tilt, in the absence of any orthostatic hypotension, and we need that this disorder is lasting for more than 6 months. So there is a concept of chronicity. Okay, it's not an acute condition. And this slide summarizes either the hemodynamic features as well as the symptoms in a POTS patient. So please notice the excessive increase in the heart rate upon standing as compared to the baseline or supine position better. In the absence of changes in mean blood pressure, there is a slight reduction in the differential pressure, okay, but no orthostatic hypotension. Well, when the patient is supine, there are basically no symptoms, but a mild anxiety, which may be the chronic situation for the patient, whereas symptoms, they occur as soon as the patient got up in the upright position, and they are consistent with palpitations, shortness of breath, lightheadedness, dizziness, fatigue, reduced exercise tolerance, pre-syncope, and very rarely syncope. Okay, based on the first 4 or 5 symptoms over here, for those of you who got in touch with the long COVID, you may recognize a number of symptoms accounting or present also in the long COVID syndrome, okay? So as I mentioned, there is a 4.5 up to 1 ratio being the disease more frequent in young women, with a history of stress like viral infection, delivery, surgery, trauma, especially infection. Okay, I'd like to remind you that this disorder was previously described for the first time by Dr. Da Costa. He was a doctor working in the military service during the Civil War in the United States, and he realized that many times in the Unionist troops, when there were major infections, pandemia, especially gastrointestinal infections, okay, the months later, a significant part of the soldiers were unable to combat. And as a matter of fact, few of them were killed because, you know, general and officials said, well, this is just nothing. You are trying not to be a good soldier. So we are gonna kill you just because you refuse to fight the enemy. Okay, having said that, this is a very disabling condition which reduces the quality of life and the working capability of the subject. A huge number of them, they lose, this lady, they lose their job. They become unable to work. So it becomes also to be a social problem. Let me address with you these 3 points, which are important to properly understand what is POTS. First, its relationship with syncope. So there are data, one comes from this good friend of mine, Satish Raj, who now I met him at Vanderbilt University in Nashville, where he spent more than 10 years. Now he's still back in Calgary, at the University of Calgary. And based on a study from him and his colleague, POTS had a POTS patient in up to 30% of POTS patients, he could find out neurally mediated syncope. So it seems that in 1/3 of patients, neurally mediated syncope may be present. But can I ask, well, we are very few, but can I ask you if any one of you ever suffered in his life of a transient loss of consciousness like neurally mediated syncope? I suffered in my life. I pass out. Who is suffering? No? Nobody.
Yeah,
So
I think I suffer some syncope symptoms, but I didn't lose consciousness. But it's maybe pretty close.
Okay, maybe very close. So let's imagine you are here. We do a rough calculation. So 2 people out of 2, 4, 6, 8, 9, it could be around 30%. So we are normal people. We are not suffering from POTS. So what I'm trying to demonstrate, that within this number, there are also normal subjects. So 30% is nothing, because 30% is not my experience. I did a study comparing young athletes, swimmers, belonging to the Italian national team with healthy controls. They were 16, their mean age was I guess 16, 17, okay? And we saw a 36% of vasovagal syncope during a team maneuver in athletes as compared to 18, 20% in healthy control. So still 20% is a huge number, okay? So telling us that neurally mediated syncope is a very frequent and safe phenomenon. Okay, so it doesn't mean so that much, this number, to me at least. Even worse is the case of Chusky, who watching in a retrospective study to the potential onset of vasovagal event, he reported a 45% of rate of syncope in a POTS population. My personal experience, as you have already understood, is completely different. I do believe that very few of none of POTS patients experience vasovagal syncope during, for example, an adaptive test, okay? Okay, second point to be addressed, symptoms unrelated with orthostatic intolerance. So what is interesting in this syndrome is there are also a number of additional symptoms which are unrelated to the incapability of keeping the upright position. And here is a table with orthostatic symptoms list, but also with the non-orthostatic symptoms, including nausea, which is very, very common, vomiting, constipation and diarrhea, featuring the picture of a irritable bowel syndrome sometimes, which is very common, okay? And there are also what we call generalized symptoms, which may be associated, like sleep disturbances and especially fatigue. So fatigue is a common symptoms, which opens the problem of the third issue I highlighted over here, POTS overlaps with other so-called functional disorders, including chronic fatigue syndrome, joint hypermobility and Ehlers-Danlos syndrome, functional GI tract disorder like irritable bowel syndrome, as I said, fibromyalgia, and I would say the long COVID-19 syndrome also. But if we consider, for example, chronic fatigue, in chronic fatigue, fatigue is the most important symptoms. In POTS is orthostatic tachycardia, okay? In fibromyalgia is pain, generalized pain. Okay, so according to what symptoms or physical signs is more important, you may consider a patient affected by chronic fatigue, fibromyalgia, or POTS. Okay. Those are the most appropriate criteria. Part of them I've already mentioned. Just let me here highlight that you need the occurrence of 2 or more of the following symptoms you may see here, which are, some of them are linked to the inadequate cerebral perfusion, such as lightheadedness, fatigue, palpitation, headache, nausea, pre-syncope or syncope during the upright position, okay? We can identify 3 phenotypes of POTS. We have the neuropathic POTS. We have the POTS associated with the poor gravitational and physical conditioning. So where patients are gravitationally and physically deconditioned. And we have this particularly important, as to my talk today, group constituted by hyperadrenergic POTS. Here are summarized the major hemodynamic, plasma CATs, and other test differences among neuropathic POTS, hyperadrenergic POTS, and deconditioned POTS. For example, if we focus on heart rate during the head-up tilt, we see that neuropathic POTS still have a quite important increase in heart rate as compared to healthy control, but not that much as hyperadrenergic POTS, and a little bit more than deconditioned POTS. As to blood pressure, neuropathic POTS may be characterized by a mild decrease in blood pressure, whereas we said that hyperadrenergic POTS don't. As to the plasma CATs, in neuropathic POTS, they are normal during the upright position, whereas they go over 600 picogram per milliliter in hyperadrenergic POTS. The only test that may differentiate neuropathic POTS from hyperadrenergic and deconditioned POTS is the QSART. The QSART, you may remember, is a test which I personally, I can't say I dislike, but I don't like that much. It seems to me quite complicated, and it's a semi-quantitative assessment of your sweating capability, okay? But this sweating capability may show you a distal anhidrosis, so incapability to properly sweating, which is on the other side normal, either in hyperadrenergic POTS and in deconditioned POTS. Finally, what we call the autonomic storms, which means a rise of anxiety together with huge palpitation. The patient feels the thoracic pain, said, well, am I about to die, is much common in hyperadrenergic POTS, whereas it is absent or very infrequent in neuropathic POTS, and is absent in deconditioned POTS. Okay, so dealing with hyperadrenergic POTS, in this subset of patients, we found out evidence of an exceeding centrally derivated sympathetic overactivity, which was associated with a remarkable reduction in the cardiac vagal modulation when the patients were supine. And so in this way, we classify them hyperadrenergic POTS, and this is an example of a patient suffering from POTS at those time. So this paper came out in 1998, and we were recording this patient in 1995. So at those time, we called the disorder chronic orthostatic intolerance, highlighting chronicity in the orthostatic intolerance. Nowadays, we can call it POTS. Okay, but basically it is the same. So please notice that even in the lying down position, the heart rate of this subject is greater than the healthy control. And in addition, if we look at the muscle sympathetic nerve activity, you may see that at baseline, while the patient is in a supine position, the muscle sympathetic neural discharge, which means the sympathetic neural activity to the vessel, is greater in POTS than in healthy control. And whereas during the upright position, the POTS patient couldn't increase that much the sympathetic activity, which was similar to the healthy normal subject, whereas the heart rate was absolutely very high. Okay, and those are the data in the population. But what is interesting is that because of this, of what I showed you, the capability to increase the sympathetic activity to the vessels is highly impaired in POTS patients, together with the exceeding shift of the autonomic control towards a sympathetic predominance. This LFHF index was taken from the spectrum analysis of heart rate variability. And this tells us that there is an excessive presence of the low frequency component, or low presence of the HF component, which is the vagal related component. Okay, so huge increase in heart rate and in the sympathetic activity to the heart, incapability to properly increase the sympathetic activity to the vessels. Okay, and here are the take-home message. I would like to add that in pandemic time, POTS features what is a post-viral, post-COVID-19 syndrome, which is the long COVID, okay? POTS therapy, here. This is why I wanted to show you, my dear young colleagues or students. No, there are no students, they are all kinesiologists. Okay, so physical exercise. I do consider physical exercise the cornerstone for the treatment, the most important therapy. The second one I put in black characters is ivabradine. But is ivabradine curing POTS? No, not at all. Ivabradine is just controlling the heart rate when the patient is standing up. So it blunts the increase of the heart rate, giving the patient with POTS more adherence to physical exercise. He becomes more prone to do physical exercise. Additional agents, as you may see, are non-drugs agents like water and salt, increase water and salt, because there is the chronic hyperadrenergic state. If that is the case, is associated with a chronic hypovolemia. So giving water and salt may improve that chronic hypovolemia, thus reducing the hyperadrenergic state. Fludrocortisone for the same reason, elastic support hosiery for neuropathic POTS. And for neuropathic POTS in the presence of a lack of peripheral vasoconstriction, midodrine, and in some cases, you may have paradoxical drugs. I'm expecting you jump on your seat, say, well, giving beta blockers? Well, beta blockers may blunt the increase in the heart rate, so may act like ivabradine. So why am I choosing ivabradine as compared to beta blockers? Because each beta blockers, even the more even those of the last generation, I mean the most selective beta blocker, they still have some kind of general effect resulting in some sort of hypotension. And we do not want to make this patient becoming hypotensive. Okay, so although beta blockers represent theoretically the best classes of drugs to be used in this disorder, I personally am using and strongly suggest to you to use ivabradine. Very low dosage, you know, half a tablet, 1/4 of a tablet, just to blunt the increase in the heart rate. And your patient will follow you much easier. So if there are POTS patients with a hyperadrenergic phenotype, then it seems reasonable to hypothesize that if I can use a technique which blunts such a overwhelming sympathetic activity and may increase the vagal activity to the heart, I may reconstruct the sympathovagal balance, possibly resulting in lower heart rate, in lower heart rate either while lying down as well as in the upright position. And as a matter of fact, this technique is now available, is the transcutaneous vagus nerve stimulation, which we call TVNS. That is a relatively new, non-invasive, reasonably inexpensive and safe methods to stimulate and increase the activity of the vagi or of the vagus nerve to the heart. This technique has been already approved for a number of disorders you may see here on the left list: depression, tinnitus, epilepsy, migraine, cluster of headache, chronic pain, and is now under interest and because it appears to be preliminary effective in fibromyalgia, in some form of pain in Parkinson's disease, rheumatoid arthritis, atrial fibrillation, heart failure, very important, dementia, and what we would wanted to test was its effectiveness in POTS. Okay, and indeed preliminary data by Dana Schiffer from our group and from this good friend of mine, Andre Diedrich from Vanderbilt University. We are doing a study together. It's a multi-center study, and here Professor Zamunér is also participating to this, which is really a multi-center and multi-country studies because it includes Chile, the United States, and Italy. Okay, so preliminary data suggests that the use of a transcutaneous vagus nerve stimulation in POTS may reduce orthostatic intolerance symptoms, therefore improving quality of life and working performance in this population. So the aim of the study, I'm going to present to you preliminary results, was to evaluate whether a 14-day lasting use of transcutaneous vagus nerve stimulation for 4 hours a day, so 4 hours a day for 14 days, okay, resulted in a group of hyperadrenergic POTS patients, resulted in a reduced dysautonomia symptoms intensity and in a change of the cardiovascular autonomic profile consistent with a decrease in mean heart rate, increase in cardiac vagal modulation, and decrease in cardiac and vascular sympathetic activity. So 23 POTS were studied. We focus, those are the inclusion criteria, those are the exclusion criteria. I get bored in listing them, so you may find them should you be interested. What is interesting is that these autonomia symptoms were assessed using the COMPASS 31 questionnaire, which is a questionnaire that is subdivided into different autonomic domains. One is the orthostatic intolerance domain, vasomotor domain, secretomotor domain, GI tract, genitourinary and populomotor domains. And we have also a total COMPASS score, which is a comprehensive index accounting for all the different autonomic domains, okay, or including all the different autonomic domains. The signals we recorded are basically the RR interval or the heart rate, continuous blood pressure, respiratory activity, and muscle sympathetic activity. Now, finally, I'm telling you what I promised since the first slide. I'm telling you what is this muscle sympathetic nerve activity. Can you recognize this guy over here? Yeah, do you recognize him? Yes, it's Professor Zamunér, who is an expert in stitching the nerve. Here is his needle, which is an insulated tip needle, which is inserted through the skin into the peroneal nerve looking for sympathetic fascicle. Sympathetic fascicles are full of sympathetic nerve fibers going to the muscle of the leg, okay? And so this is the raw signal with the sympathetic single fiber discharge, and this is the integrated signal, the one we are using for research purposes, the easiest to be used. So we integrate this kind of, we manipulate this raw signal in order to get the partially filtrated and integrated final signal with the sympathetic bursts like this one, this, that, which are the sum of single fiber sympathetic discharge activity. And this here, it's a very nice example. Do you recognize the Valsalva Maneuver? Okay, so there is a drop in blood pressure associated with the progressive reflex increase in heart rate, you see, with the increase in the raw signal activity, which is clearly very well represented by a beautiful, congratulations, Beta, a beautiful integrated sympathetic efferent neural signal to the vessels. Okay, please notice that during phase 4, when there is the blood pressure over drive, there is a reflex drop in heart rate and a neural silence, no more sympathetic activity. So this tells us that Professor Zamunér got the needle in the right place and got a huge number of sympathetic fibers information. Okay, having said that, after 14 days of transcutaneous vagal nerve stimulation, so again, there are slides that do not come out. This is a tricky story of mine. There are hidden slides into this presentation because I wanted to show you the device, and I just realized that I happened in a meeting. I was prone to say this is the instrumentation, and it didn't come. And today it is the same. How can we say? How can we deal? Because it's yeah. Let's go. Possibly. Sorry? Let's go in a not in a full screen. No. Back. Possibly back. Back. Okay, so some here, but let's go not in a full screen. Okay, let's see if this. Okay. Okay, let's do this way. Sorry for the guys, for you guys. Okay. Down. Okay. Is hidden. Okay. Okay. Thank you, Beto. Thank you very much. So this is the instrumentation we used. Okay, I wanted to show you. So this is a stimulator, is a battery-powered stimulation, very simple to be used. We can modify the intensity of the current, which is given at the right air, and this is because of the maximum power of the stimulation. At least in right-handed individuals, okay? And this is the area where we stimulated. This area, the concha cimbe, was proved to be highly innervated by vagal afferents. And so by giving electrical current from here, we stimulate vagal afferents which go, and the stimulation goes to the nucleus tractus solitarius here, which is under the suprabulbar center's control. And by the end, this stimulation may result in an increase in the vagal efferent activity to the sinoatrial node here, okay, and in a reflex decrease of the sympathetic activity to the heart, okay, see the sinus mine, and of the sympathetic activity to the vessels, because the nucleus tractus solitarius is connected with the rostro-ventro-lateral medulla, from which the neurons going to the sympathetic ganglia are located. Okay, so this is the supposed anatomy involved in such a kind of stimulation. Okay, okay, we have seen everything. This is okay. Results. Basically, this kind of stimulation, chronic stimulation, resulted in a reduction in symptoms of orthostatic intolerance in our population, in the intensity of GI tract symptoms, and in a total compass score. So the greater the total compass score, the greater the dysautonomia, or the greater the symptoms intensity altogether. Okay. It goes crazy. Oh gosh, here is my young colleagues. They like so much this stuff, which results in a loss of time. Okay. Sorry. Okay. So we talk about symptoms. Now we talk about the autonomic profile. So there was a tendency to reduce the heart rate. If you go to the heart rate, pre-TVNS was slightly greater than post-TVNS, but was not significant. There was a significant reduction in the burst per minute sympathetic discharge to the vessel, muscle sympathetic nerve activity, so it was reduced, and the HF component of RR interval variability, which is a recognized index of the vagal modulatory activity to the heart, was increased after electrical stimulation. Okay, that's it. Okay, so this technique seems to be quite promising. Now, there is the last part of the protocol where we are assessing the patients 3 months after, 3 and more months after the chronic stimulation ended up. So we are hoping they are slightly coming back to their disease, let's say, in terms of study, of course. This is to demonstrate that, of course, this technique has to be done, if not continuously, quite frequently at least. Okay, questions? If somebody has got energy, still energy to, and didn't sleep too much. I didn't.
About the stimulation, is it continuous? About the protocol?
Yeah.
How many days, how many times?
So I didn't say that okay, so the stimulation, as I told you, so before giving the device to the patient, we test the maximum amplitude of the electrical stimulation that single patient is feeling. Okay, we don't want much discomfort, but at the very beginning, a little bit of discomfort may be present because you feel something like pinching you into the hair, which is a strange situation. But there is an early adaptation. So let's say 10 seconds after the onset of the stimulation, the patient is okay. How long does the stimulation work? It stimulates 30 seconds and then stop for 30 seconds and then start again for 30 seconds and so on. It is a squared waves of stimulation based. I said that we can't change the frequency of stimulation. The one that this device got was previously developed by André Diedrich, who did several experiments changing the frequency of stimulation. To tell the truth, I don't remember the frequency of stimulation. We may, if you are interested, we may find it out. So I told you about the duration of the stimulation. The patient are asked to stimulate themselves 4 times a day for 1 hour. So the device, every single, after such a kind of stimulation, the device has to go under recharge. So it has to, basically it's like a cell phone, okay? Otherwise, it has to be replanned, reprogrammed, okay? We suggest the patient to do 1 hour as soon as he got up in the morning, 1 hour before going to bed. For example, is great to improve quality of sleep. And to that's something that in almost every patient, they say, well, I slept. It didn't work too much on my tachycardia, somebody is saying, but I slept much better. Okay. How much? So, so far, this device, which is no more available, there are other more developed, I mean, costed around 3,000 euros each. Okay, so we could start the study because of a liberal donation. We hadn't money. And then there was a deal with the company. We said, well, you gave us additional 4 devices. We mentioned this because otherwise we won't be able to do the study. So it turns out that in few patients, this device worked extremely well. And they decided by themselves to go to the company and bought the instrument after the study, okay? So we don't have full data showing the successful rate. I mean, what I can tell you is that as one could a priori expect, is that the worse the symptoms, the better the effect, okay, as a general rule. It worked in particular on pure POTS. We decided, so I showed you the data of pure POTS patients. But as a matter of fact, in the general protocol, we included patients with orthostatic intolerance, but not hypotension. So we had several fibromyalgia, several chronic fatigue. We had a number of Ehlers-Danlos syndromes. For example, Ehlers-Danlos syndrome is responding extremely well, but they behave like POTS. They are basically POTS, very activated in terms of sympathetic activity. Okay, so the best results we got in Ehlers-Danlos. The worst results we got in chronic fatigue. In chronic fatigue, it seems it didn't work that much, but possibly chronic fatigue overlap mostly with neuropathic POTS. So they don't have excessive sympathetic activity. They and probably because of that, the rate of the successful rate is quite poor. Is there any other question from you? And don't forget that this, okay, from the web, tell, okay?
Thank you for your presentation, Professor.
Yeah.
I have a question about the criteria of POTS, because I work with a group that investigate about POTS with mathematical models, and they found that there are patients that didn't reach the 30 beats per minute of heart rate, but they still have the symptoms. How flexible are the criteria to the diagnosis of POTS?
Well, so it's okay. Let's consider. Okay, let me go to the criteria. Okay. Okay. So those the one I'm showing you right now are the classical criteria we are using in order to talk each other among researchers. Okay, POTS is an heterogeneous disorder and is a syndrome. So as I should have highlighted, there is a huge overlap with other disorders, including fibromyalgia, including chronic fatigue, Ehlers-Danlos, and other, which makes the point of the definition subtle and not always clear. Okay. The point you touch is important because you may know that also friends from people I consider a friend. Few years ago it came out. My paper on circulation, the one on COI, C-O-I, I showed, was the first one out on the pathophysiology of POTS, published in a good journal. Okay, so people were looking at that, but having slightly different inclusion criteria as the one I used, they found different things. For example, it is not that easy to get pure hypoadrenergic POTS patients. Absolutely. It is much easier to get neuropathic POTS. Don't ask me the ratio between the two conditions. I don't know, but basically that is the case. So, sometimes if you have to do a study, you include other patients. And it turns out that people were having results quite different from the one I just showed you. And so somebody came to me saying, well, do you know, you are the only one who could find out this subtype of hypoadrenergic POTS. So I got really angry about that because there was a subtle idea that I was changing data, that I was misusing data or doing something. There is another point very important, which explain you why there are so heterogeneous results on POTS. The fact that you never know, nobody of us is including POTS according to the duration of the disease. For example, it is my feeling that new POTS patients, they have a greater chance to be hyperadrenergic than long-lasting, that POTS patient having long-lasting symptoms. Did you get my point? So it seems that at the beginning, so it may be the same disorders that some researchers, including me, are catching at the beginning of the disorder as compared to long-lasting disease. Okay, it may be that at the beginning you may have a huge capability to have a huge sympathetic activity to the heart, and by time you lose this capability because the disorder goes on and you do not recover, and it goes to a neuropathic POTS. So that did you get my point? So it may be one of the reasons we see two phenotypes, as well as we had different results in the history of POTS in research, okay, might be due to the fact that we get the disease at a different level.
Right, I got you. Thank you very much.
Okay, no, that's, you're very welcome.
And I have a second question if we have time.
Yeah.
How the device, how or did you study how the action of this device affect the heart rate variability, and my question is because in the low frequency band, there is still a lot of question about how interpret this low frequency band, because there is some researchers that said that there is a parasympathetic and sympathetic component, so it's a little difficult to interpret it. So do you think that in a healthy subject, the use of this device could help us to analyze and try to understand how the parasympathetic is affecting the low frequency band? Is just a question that I figure out.
Okay, I'm trying. Could you heard? No, I'm replaying the question. So the question is, can I have your name, please, from the web, the one who made the
Martin.
question? Martin was highlighting how the low frequency component of heart rate variability is still, to his perspective, is still unknown in terms of functional meaning, okay? In the sense that many researchers, they claim that is a mixed component. Can I make a brief comment? So he was asking, let's go to his question. He was asking whether this technique, the transcutaneous vagus nerve stimulation, may help to disentangle the vagal and the sympathetic component within the low frequency component of heart rate variability. So let's go quickly to the answer. I don't know. Basically, we are focused on the HF component, either in absolute or in normalized values, as well as on the low frequency, high frequency components, okay? Which being a ratio, should, if the low frequency components is having some vagal component, let's say, the ratio should abolish it, because the other is a vagal component. As to me, I come from a group that has been spending a number of years and doing research and experiment both on humans as well as on animals. Don't forget that we worked on acute animals and chronic animals, and in chronic preparation, which means animals that underwent surgery and they were exposed to beta blockers, alpha-lytic, or we could, in some of them, cut the vagi and make sympathetic stellectomy, okay? So nobody has done concomitantly animal, acute and chronic, as well as humans, as we have done. So there is huge evidence that if you are using the absolute values for assessing the low frequency component, you don't go anywhere. So the low frequency component is very related to the total variability, as it is to some extent the HF component, but the low frequency one is much more. So you have to use the normalized value, which means the amount of the low frequency component divided by the total variability, or you have to use the ratio. If you use the normalized values, there is a huge evidence derived from both animals and human studies that the low frequency component does reflect the sympathetic modulation to the heart, not activity. It's not phasic. It's not static. It's dynamic. It's phasic. Okay. So this is my personal opinion. Okay. Do you know why? So what you are claiming, and I know very well that a great part of the researchers, they do believe that the low frequency component is mixed, is because we do forget that the original study from Pomeranz giving animals atropine, giving humans, atropine, in order to reduce the vagal efferent activity, and and they could reduce also the low frequency component. This is just because reducing the vagal activity, you increase the heart rate. And in doing that, you highly decrease the total variability. Therefore, if you use absolute values, both the HF component is reduced, but also the LF component, because the amount of information you are dealing is reduced because of atropine. Okay. So we should remember that that study was an early study and was quite, at those times, it seemed very powerful. I mean, no doubt about that. But it has a number of weaknesses. And based on those weaknesses, first of all, the fact that he was considering two different, he didn't care about difference in total variability, in total heart rate variability between the pre-atropine as compared with the atropine condition. Because of that, nowadays, this study should be highly criticized. But unfortunately, as it happens in science, when a simple concept is spread out, it's simple to be used. You just say it's a mixed component, okay, you are done. But please use the normalized units, which is something that I'm always asking when I'm acting as a referee. Okay, incidentally, if a referee will ask you to use the normalized unit, or at least to show normalized in your tables also the normalized unit, it's me. Okay, so I put a signature on my revision since now. Okay, was my explanation too long to you?
Oh no, was excellent. Thank you very much.
Okay, so never forget the total variance. Okay, total variance is crucial. If you normalize, you take away changes in total variance, and you can compare patients characterized by different variance, groups of patients characterized by different total variance, and so on. Okay.
All right. Thank you, Professor.
So that's a methodological point. We have been fighting for years on that methodological point. But thank you very much for having highlighted this point, because still, we are always providing in our tables absolute values of LF and HF, always. But please help us to convince people to provide also normalized values. And you will see that normalized values will give you more information than the absolute values.
The absolute values. All right. Yeah, actually, that was a question in my commit of my PhD program, and was very hard to respond to answer that, because there is a lot of papers that say things against the other. So it was very nice to hear a good explanation from you.
Okay.
You.
Should you have? Okay, this colleague of yours is claiming that he's about to complete his PhD, and to some extent he underwent criticism about the interpretation of the low frequency component. So this is the reason he was asking. I might ask you to go through Professor Zamunér, or if you have got a pen, I can give you my email address. And should you be in trouble to reconstruct my thought, because I went very quickly, I apologize, but there is no much time. I can send to you some manuscript, or try to explain you plainly this concept of normalization and why we went to normalization. That was a further step we achieved. We didn't start from a normalization, okay? We start from absolute values, as everybody, okay? I must tell you something more. We were, at the beginning, we just measure the height of your spectral component. So when I was young, I had a Righello, and we were drawing a line and measuring in millimeters the amplitude of the spectral component, trying to, before assessing the area of the spectral components and before going to normalization, because we realized that there were, for example, let me give you another tips. If you do a physical exercise, a normal athlete is characterized by a total variance, which could be around 4,000 squared milliseconds. He's good, healthy. If he does physical exercise, light physical exercise, it goes to 1,000. If he does medium intensity exercise, it may go to 100, or let's use 4. I said 4,000. It goes to 4,000 goes to 1,000, so 4 times less. But if the athlete goes to intense physical activity, it may be 100 square milliseconds. So 10 times or 100 times less. Okay, no, what is it? No, it's 100 times, 400 times less. So how can you compare any spectral component at baseline and during exercise in this guy? Just doing normalization. Otherwise, you will always see a decrease in the low frequency component and a decrease in the HF component. Let me tell you that those researchers, they are, for them, it is okay. Physical exercise, reduce the vagal activity, reduce the HF. Everything was fitting. Very good. Excellent. Apart from the fact that total variability was decreasing a lot, And so, so I would like to finish with the words of criticism for those researchers, because, the concept of HF reducing, for instance, during exercise or during the upright position was easy to be eaten because it fit with normal physiology. Everything was fine. So they focus on the absolute values of HF. And since they like they didn't like to think too much, let me be critical and a little bit bitter in my comment. Okay, they discharge the functional meaning of the low frequency component. Okay, if you lose your low frequency component, which is the same in blood pressure variability, we hadn't the time to show today, but it is the same in the sympathetic discharge activity. So you have seen that the sympathetic bursts, they come out in volley. Okay, during the upright position, these volley are synchronized according to a low frequency rhythm. So a healthy state human being staying in the upright position has to have low frequency component either in the muscle sympathetic nerve activity discharge, in the blood pressure variability, in the heart rate variability, and possibly if you are going to assess other variables, even then. Do you want to know something? Before vasovagal syncope, you lose this rhythmicity. Okay, still you have the sympathetic drive, the sympathetic fibers discharge into the vessel, but this is unuseful. You can't have a proper vasoconstriction if you do not modulate at 0.1 Hertz, which is the low frequency component. And if you have so important low frequency rhythmicity in the vessel and in the neural activity to the vessel, let me ask you why you should not have low frequency sympathetic related component into heart rate variability. Why? Do you think that our body is built up in a different way to the heart and to the vessel? Could the good God think to be, I wouldn't trust in God if he was so stupid. I mean, sorry for having said that. I don't want, just please take the words in the correct way. I mean, if I'm going to, who are a human being, okay, very limited. If I'm going to build something, I will build the same way a control system to the heart and to the vessel. I wouldn't go up such apart to systems that are talking each other. Did I convince you from the web?
Absolutely.
Yeah, I thought you ran away. I thought you were running away. Okay, I'm going to shut down my mouse.
Oh, it was so interesting. Actually, my thesis is about synchronization of physiological signals. So here you talk about it is really nice. So thank you.
What physiological signal did you record?
I'm study MSNA, muscle sympathetic nerve activity, with respiration, with blood pressure and heart rate, and we
Okay.
are looking for differences in pregnancy. Where
Difference in pregnancies. Ooh. So did you teach the nerve in a pregnant woman?
Yeah.
Oh, congratulations. And
So,
congratulations to the woman. It's not dangerous, but you may not. I think it's a hard protocol. And did you do coherence and cross-spectrum analysis between your parameters?
yeah, we start with that analysis, but then we want to go to the next step and analyze phase coherence to try to study synchronization and not just coherence. So to study synchronization, we have to be sure that the differences of the phases are constant in time. So that's why we study the phases of the signal and not just the amplitude.
Okay, but don't lose time with phases. Phases, there may be a delay, a physiological delay between the neural innervation and the answer of your smooth muscle. Go on mostly on coherence. You will see that there is a huge coherence. Of course, if you are dealing with blood pressure and muscle sympathetic nerve activity signals, you will have a huge coherence in the high frequency component, of course, because there is a huge modulation of the respiration of the muscle sympathetic nerve activity. But if you use a stimulus, some kind of stimulus like the upright position or, then you will find out a coherence also in the low frequency component among all your signals. Okay, I think that my audience here is yawning, so they are about to syncope, even if they are sitting down. And thank you. Okay, there is one more question about. Sorry.
Some evidence of exercise for participation.
If there is a special kind of exercise?
There's evidence, physical exercise, that exercise is effective for them.
Yes, so there is evidence. We just went through the literature. So the group who did the best work so far is the Ben Levine group from Dallas, Texas, and the first name is Fu, F-U, is a Chinese, nowadays no more young researcher, quite nice, good aspect, quite nice, but very sophisticated and sharp mind. Okay, they did physical exercise either in the lying down position as well as in the upright position, and they could demonstrate that physical activity is improving orthostatic tolerance and other symptoms in these patients. So they did quite well. We are about to be out with similar data comparing lying down exercise with a sitting position cycling in a group of POTS patients compared to healthy controls. And what else? Yes, so there is evidence. Because don't forget that when you are dealing with POTS patients, you are always dealing with a certain amount of gravitational and physical deconditioning. But I would say by definition. Okay, so if you see a patient suffering from POTS since 4 months, as I recently happened to see, you know, the amount of physical as well as gravitational deconditioning is very low. You could consider it absolutely irrelevant. But for those who are suffering from this disease for many years, this could be a huge part of their problems. And so here, you know, physiotherapists as well as kinesiologists, especially kinesiologists, I would say, here they jump on the stage. Here is their role in finding out a balanced way to enhance straight aerobic capability and, you know, muscle mass, basically, with the mixing up in a different manner the type of exercise over time. Okay, I just, you know, I'm a simple man on that sense. I just mixing up isometric exercise and aerobic exercise, but you guys have more capability than mine to do quite good protocol. And I would be glad to see in literature somebody of you coming out with a, you know, with something practical to be used. Okay. You want to close?
Ok, estimados, muchas gracias. No sé si hay alguna última consulta para ir ya dando término a la actividad. Ok, estimados, muchas gracias por estar ahí, por estar presente en ese evento. ¿Ya? Cualquier duda, ustedes pueden enviar un correo. No sé si tienen un correo, yo puedo dejar aquí mi contacto también. ¿Ya? Lo voy a dejar aquí en el chat del evento. Para cualquier duda, ¿ya? La charla también estará grabada para los que están inscritos y para que puedan descargar también. ¿Ok? Así que eso, muchas gracias por la atención. Vamos a dar término a la actividad.
So thank you to everybody.
Mm-hmm.